Hello, everyone. My name is Jason Dunphy, and I am with the Wound Care Education Institute, powered by Reliance LLC, and I would like to welcome you all to the webinar today titled Wet-to-Dry Dressings Substandard of Care. Our program today is made possible by a grant from Shield Healthcare. Next slide. This particular event has been created to provide an opportunity for education related to clinical topics that affect the wound care market today. WCEI is now a Reliance LLC company and continues to have one goal in mind: to improve the management of wounds and ostomy for patients across the nation. We currently support over 20,000 alumni through resources, webinars, seminars, our conference, as well as certification courses in wound care, diabetic wound care, ostomy, and nutrition wound care. Next slide. So before we begin the webinar, I'd like to run through a couple housekeeping items. For those of you interested in obtaining educational credit, you will receive an email from WCEI within 48 hours with the evaluation for this program. You must complete the webinar and evaluation within 60 days from today to access your CE certificate. Double check your spam folder for those emails after 48 hours. There is a handout available for the presentation today. You can click the attachment in the handout section to download or print if needed. The actual CE presentation should last about 60 minutes. If you have any questions for our presenter, please feel free to submit them in the questions box at any time during the webinar. If time allows, we will have a Q&A session at the end of the webinar. You must be logged in on a computer, tablet, or mobile device and viewing the slides. No credit will be awarded for those who use audio only. The accrediting body for this program is on the screen now. Next slide. And now I would like to introduce our speaker for today's presentation, Dr. Don Wilhelm. Dr. Don Wilhelm is board certified in general surgery by the American Board of Surgery. He has over 25 years of experience in general vascular surgery and wound care, as well as extensive experience in medical legal consulting and teaching college advanced science courses. His teaching style includes emphasizing the fundamental topics of wound care, incorporating additional visual aids, and utilizing clinical scenarios during his presentation. He is the lead instructor for Diabetic Wound Certified course and is also on the editorial advisor boards of Wound Care Advisor and Wound Central Electric Journals. Hello, Dr. Wilhelm, and welcome.
Well, thanks, Jason, and all of you that are hanging in there. I apologize for the fact that you didn't hear me the first go round, but that's okay because that's where I made all the mistakes. So now I should be able to get this down just fine. Topic for today is wet-to-dry dressing, substandard of care. I'm going to talk a little bit about dressings, then go specifically into wet-to-dry dressings, how it should be utilized, what its downfalls are, and why we should discard it at this point in time. But it's not in your best interest for me to tell you something's bad without coming back and sharing with you what you can use. And we'll be talking about debridement because wet-to-dry dressing falls under mechanical debridement. And then we'll also be talking about the various dressing categories because a lot of times, up 75% of the time, wet-to-dry dressing is used incorrectly in the wrong healing phase. Selecting a dressing is a complex process. It's not just the dressing selection itself. There's multiple factors that need to be taken into consideration. Ideally, what we'd like to do is we'd like to select dressings that are evidence-based, but at least standard of care. Regardless of where we practice, we are going to be held up to standard of wound care guidelines that exist, not only just in this country, but internationally. To me, the primary goal is to heal the wound as quickly and painlessly as possible. What this means is that I want to get the wound resurfaced. We want to get new epithelialized cells over it as soon as possible. This will protect the wound bed from environmental contaminants, which may slow down and maybe even stop the wound healing. In order to heal any wound, we need to hopefully eliminate, but at least control what caused it in the first place. So, for example, a pressure ulcer is caused by compression or compression with friction and shearing. What we need to do is we need to get rid of the compressive forces, download it, offload it, I should say, in order to heal that up. We got to look beyond just the dressing. We have to provide systemic support for our patients. This may include their environment, where they live. This may include their nutrition, may include their activity. To heal a wound, we need to understand that it needs to be in a local wound environment that is physiologically in the best interest of the wound. This dates back to 1962, when a British surgeon, Dr. George Winters, proved that in a moist environment, wounds can heal twice as fast compared to that of a dry environment. So we want a moist wound healing environment. Not dripping wet, but a moist environment. We may consider the utilization of a dressing either as a primary or secondary dressing. The primary dressing is what touches the wound bed first. It may be a powder, such as nystatin. It may be water, such as a hydrogel, amorphous gel, or it may actually be a solid, such as a foam, such as an alginate, such as a hydrocolloid. Whatever touches the wound bed first is the primary dressing. Everything after the primary dressing is considered the secondary dressing. Now, when I write orders, I understand that the people that are taking the orders off may not understand the differential between a primary or secondary dressing. They may actually be waiting for something known as a tertiary dressing, which doesn't exist. So what I do then is I will say, use this dressing or therapy, followed by this, followed by this, followed by this, followed by this. Give them the exact order that I want them to apply in an attempt to heal that wound. Any dressings that we select, we need to understand if they're indicated for that wound. This will come from the manufacturer's research. Also, contraindicated. A couple of the dressing categories are contraindicated over infected wounds, and I'll talk about that in a little bit. As I mentioned shortly, just in the recent past, we need to maintain a moist wound healing environment. Our cells, our viable cells, our tissue are alive in a moist environment where they may not be alive and may die in a dry environment. Some of the factors we need to take into consideration, the exudate. If there's minimal exudate, we may need to add moisture to it. Category, hydrogel, 90% water. If, however, there is more exudate than what the wound bed needs, then we need to absorb the exudate. We may think of such things like a foam or hydrocolloid. That doesn't work. Maybe go to an alginate. That doesn't work. Go up to a specially absorptive. Bioburden can really slow down the wound healing process. What bioburden refers to is microbial load within the tissue itself, the bacteria within the tissue. Now, with chronic wounds, we have to understand that with chronic wounds, the bacteria are protected. They place themselves within a polysaccharide envelope. This is known as a biofilm. Biofilm may be resistant to systemic antibiotics. Our immunoglobulins may be resistant to our phagocytes, such as the neutrophils and macrophages. And so the bacteria can keep on living, dividing, and creating havoc to our patient. Pain. Pain needs to be taken into consideration. Not only is it the right thing to do, but with pain, this will slow down the wound healing process. A patient that's experiencing pain, they will secrete catecholamines such as epinephrine or adrenaline. And what these chemicals do, they cause basal constriction. And what vessels they constrict are going to be the farthest ones out from the arterial tree. These will be the capillaries within the dermis. So under the influence of epinephrine or adrenaline, we're going to develop the vasoconstriction. What does that mean to the tissue that we're trying to heal up? Less blood flow there. That means hypovolemic. Or there may be less oxygen getting there, hypoxia. Anything that causes vasoconstriction, such as pain, each cigarette somebody smokes will lead to 1 hour worth of vasoconstriction, a cool environment. Anything that causes vasoconstriction means there's going to be less blood flow to the wound bed, which means less cells of repair, oxygen, nutrients for that repair, which in turn means that with vasoconstriction, we're going to slow down the wound healing process and actually increase the chances of infection. And bleeding needs to be taken into consideration. Obviously, it's going to need to be controlled and hopefully prevented from occurring again. Now, this may be a unique concept to some of you, but the frequency of dressing changes has a very important role. What happens every time you take a dressing off, because of what's known as the evaporative cooling of the wound bed, what do we have? Vasoconstriction. And with this vasoconstriction, it's going to take about 4 hours of time now to get that wound bed back into the healing mode. So the cells start dividing, the mitosis will start occurring. 4 hours. So let's take, for example, as we can see in this diagram, changing a dressing QID. Let's go ahead and take the gauze dressing. Well, if we change a gauze dressing 4 times a day, that means 4 dressing changes a day times 4 hours, or 16 hours out of 24 hours. That wound bed is relatively vasoconstricted compared to keeping a gauze dressing on versus changing that gauze dressing once a day. Now only 4 hours out of 24 hours, we have relative vasoconstriction. So the frequency of the dressing change can have a positive when we do it infrequent, or a negative when we do it frequently effect on the patient. The dressing selection itself. Each dressing has its own inherent warmth for the wound bed. And anytime we cool that wound bed by thermal regulation principles, a cool wound bed, we're going to have a decreased blood flow, we're going to have vasoconstriction. So if you look at that upper photograph, that's our gauze dressing. That's actually going to lead to our coolest dressing. So we're going to have the most vasoconstriction under a gauze dressing than any other dressing. Look at the lower photograph. That's a foam dressing. That's actually our warmest dressing. So we're going to have less vasoconstriction under a foam dressing than we will under a gauze dressing. Have to look at what the manufacturers say. They've done the research. They've gotten the approval for their dressings. We should be utilizing these dressings per the manufacturer's recommendation. Example is if we want to use something known as Regranix on a wound bed. Regranix is platelet-derived growth factor. We can use that on diabetic foot ulcer, but it's only FDA approved for that wound. Any other utilization of Regranix is inappropriate and would be considered off-label or experimental use. So we need to know what the manufacturers say. In the lower photograph, we see the application of an Una boot. And we can use some of these dressings in conjunction with other dressings. So for example, let's say we have an open wound and we want to put an Una boot on it. It'll be a venous insufficiency ulcer. We want to put an Una boot on it, but there's so much exudate that we want to put a dressing on as a primary dressing and an Una boot on top of that. Well, we can consider foam or we can consider the hydrocolloid. The thing is, though, that the wear times have to match. So if you're going to leave the Una boot on for 7 days, you have to select a foam or hydrocolloid that can last in place for 7 days. If you only have the only foam available is a 5-day foam, then you have to change the entire system at 5 days. What about the overall cost of utilization of a dressing? Well, if our chief financial officers, our bean counters, had their way, the only thing we would be able to order would be gauze saline, and tape. Why? Because gauze, saline, and tape is relatively inexpensive. And so they're looking at it, and they're looking at the price of some of these more advanced dressings, and they're a lot more expensive. We're going to have to work with our CFOs and have them look beyond the unit cost of the gauze, saline, and tape. For example, if we can use gauze, saline, and tape and apply it 3 times a day, that means somebody's going to have to go to the patient, take off the old gauze, saline, and tape, and put on the new gauze, saline, and tape. And then they're going to have to discard it. Versus maybe a more advanced dressing that you change every 3rd day. So if you have a TID dressing change for 3 days, such as a gauze, saline, or tape, that'd be 9 applications. Versus an advanced dressing that you change every 3rd day, that's just 1 application. And then, what about the efficiency of the dressings that we select? Maybe utilizing a system, gauze, saline, and tape, it may take us 3 to 6 weeks to heal up that wound. Versus an advanced dressing that we can heal up in maybe 1 to 3 weeks, much less time. So the bottom line is this, that the more expensive dressing per unit costs, however, if it requires less frequent dressing changes and results in shorter healing times, overall, do the math, may be much less expensive. Now, let's talk about wet-to-dry dressing. It's a form of debridement. I'm going to make the statement that it has served a useful purpose in the past, but it's time to move on. What is wet-to-dry dressing? Well, it's considered a non-selective mechanical debrider. Now, there are 2 main categories of debridement where we remove the non-viable tissue. One category is selective. That means that in the process of removing the non-viable tissue, you do not remove any viable tissue. There's 3 techniques that fall under selective debridement: autolytic, enzymatic, as well as biological. Now, non-selective debridement, such as where wet-to-dry dressing falls under, the process of removing the non-viable tissue, you will have to sacrifice some viable tissue. There's 2 techniques under non-selective debridement. One is mechanical debridement, like we're looking at wet-to-dry dressing, and another is sharp debridement. So wet-to-dry dressing being non-selective mechanical debridement means that in the process of removing the non-viable tissue, we will have to sacrifice some viable tissue. Technique, in general, you're going to apply a saline or water moistened woven gauze. Squeeze it out, have it damp, place it on the dry wound bed. Let it dry out. And then in 4 to 6 hours, you're going to take it off. And in the process, you'll be taking off the non-viable tissue, but you'll also be removing some viable tissue. You do not remoisten it. You take it off dry. This is basically the guidelines in regards to wet-to-dry dressing. However, the technique is not standardized. Some practitioners will remoisten the gauze upon removal. This is actually considered a moist-to-moist dressing changes. I remember as a surgical resident, when I ordered wet-to-dry dressings, it kind of got my attention when the nursing staff, at that point in time, before they took that wet-to-dry dressing off, they moistened it up. Why? Because it's less painful to the patient. They knew it better than I did. They were right. I was wrong. Sometimes they utilize solvents other than normal saline or water. Some people use hydrogen peroxide, betadine, Dakin solution, which has hypochloric acid in it. And the frequency of the dressing change varies also. When I was in my training, 5-year surgical training, we used to change the wet-to-dry dressing every 12 hours, not every 4 to 6 hours. So in and of itself, it was not standardized. Now, there are indications for wet-to-dry dressing. what would be the indications? Well, if there's non-viable tissue in the wound bed during the inflammatory phase of full thickness wound healing. Let me digress just for a second. The phases of wound healing, full thickness wound healing, there are 4 phases. They're overlapping phases. The first phase is the hemostatic phase. What happens now, the platelets will stop the bleeding and they'll secrete growth factors. We'll know these as platelet-derived growth factors. These are chemotaxic molecules, which will draw out of the bloodstream cells, molecules, oxygen for wound healing purposes. That's the hemostatic phase. We want that over very quickly. Now, the next 3 phases are overlapping. The inflammatory, then the proliferative, and ultimately the maturation phase. I make the analogy of building an 80-story office building. The inflammatory phase. This is where the demolition crew comes on in. This is where the people will get rid of the bad stuff right off the bat and level the land. Who's going to do this from a wound healing point of view? It's going to be our phagocytes performing phagocytosis. A phagocyte is a cell that will surround, ingest, and digest a foreign antigen because it has proteolytic enzymes in the cell body. First phagocyte at site of the wound healing will be the neutrophils. Then the macrophages will be there, but they come out of the bloodstream as monocytes. And not only will the macrophages provide phagocytosis, but they'll also secrete various chemicals to keep the wound healing process ongoing, such as cytokines, which will affect the cells in the area to do a certain function, or chemotaxic molecules, similar to platelet-derived growth factors, which will draw out of the bloodstream various molecules, cells, oxygen for wound healing purposes. So that's the demolition crew, the inflammatory phase. That should last about a week. Your chronic wounds are probably stuck in the inflammatory phase. That's when you get them. Okay, now, with your 80-story office building, what we're going to do is the contractors are going to come on in, and they're going to build the walls of the building. Up to the 80 story, they're going to put a roof on it, and they're going to plug up the holes with windows or doors. And what are they doing? They're isolating the wound bed itself from environmental contaminants. That's the proliferative phase. We're going to fill with granulation tissue, we're going to contract the wound bed, and we're going to cover with the epithelial cells. The granulation tissue is actually going to be like little elevators within the wound bed itself, providing cells, oxygen, nutrients to the surface of the wound. But the minute that wound is covered, we are done with the proliferative phase. It's just like you do not want to put down your carpeting and paint the walls within your 80-story office building until it's secure from the environment. Because what if you lay down the carpeting and all of a sudden a rainstorm comes in and gets the carpeting wet? So the proliferative phase is going to isolate the wound bed from the environmental contaminants. It takes about 3 weeks. And lastly is the maturation phase. And that's going to take about 2 years. This is where your interior design people come in. They paint the walls. They put the interior windows, doors, lay down the carpeting, lay down the tile. And so what will happen with this is that underneath the epithelialized cells, the collagen which is our scar tissue, is going to increase its strength and will basically get to the point after 2 years that it is maximum strength of 80% of normal. What are the indications for WettoDry dressing? It's indicated for the inflammatory phase. It's what we want to do is remove that non-viable tissue. We want to get rid of the junk, the bad things in the area, so we can get the proliferative phase undergoing. When we apply it over non-viable tissue, it's considered a mechanical debrider. In the process of removing the non-viable tissue, it will remove some viable tissue with it. Thus, it's called non-selective debridement. What are the contraindications for WettoDry dressing? Application on viable tissue, such as granulating tissue or epithelialized wound. You apply it on granulating tissue, you may get rid of the scar tissue, the collagen formation, the angiogenesis. You may disrupt the epithelial cells. It's not intended for the proliferative phase of full-thickness wound healing. Is this an issue? How frequently are we talking about? I mean, is this a rarity where wet-to-dry dressings are ordered? Well, not really. There was a 2-year retrospective chart review. And during those 2 years, they assessed what dressings were ordered. Wet-to-dry dressings were ordered 42% of the time. There was no dressing that was ordered more frequently than wet-to-dry dressing. No dressings that were ordered greater than 10% of the time. Enzymes and dry gauze by itself were both ordered about 7% of the time. What was interesting in this review was that basically about 3/4, 75 to 78% of the time that wet-to-dry dressings were applied inappropriately. What were they applied on? The proliferative phase of wound healing. Wet-to-dry dressings is a debrider, should only be used in the inflammatory phase, not the proliferative phase. What are some of the disadvantages of wet-to-dry dressing? Well, it's non-selective. With it, we're going to remove healthy tissue, which in turn can re-injure the wound, can lead to pain and bleeding for our patient. You may think that you have a sterile dressing there, but unless you have 64 layers of gauze and you put regular tape on top of it, it won't be a sterile environment because bacteria can transfer, can go through 64 layers of gauze dressings. There's a potential that pieces of gauze can be left behind. This is very similar to when a patient has a stitch abscess. After a surgical procedure, they have a non-absorbable suture, and that wound really never heals up. It heals up, it drains, it keeps on developing infection until the surgeon removes that infected suture deep within the base of the wound. So these pieces of gauze left behind can act as residual foreign bodies and can inhibit the wound healing. Gauze, as I mentioned before, is our coolest dressing. And that means we're going to have basal constriction under a gauze dressing more so than any other dressing. Because of this basal constriction, there's decreased blood flow going to our wound bed. So we may get less white blood cells coming there out of the bloodstream, neutrophils and ultimately macrophages. Because of the wound hypoxia, because less oxygen's coming out there, our phagocytes may be less efficient. Why do we need oxygen? We need oxygen because of the fact that if you remember the process of producing ATP, which is our energy unit for our cell, in a oxygen-rich environment, 1 molecule of glucose can generate 36 molecules of ATP. In an oxygen-poor environment or hypoxic, it can only generate 2 molecules of ATP. So our phagocytes may be less effective, efficient, and this will impede the wound healing. Actually, the hemoglobin molecule itself that's going to transport oxygen from the lungs out to the periphery will hold on to oxygen molecules longer in a cool environment than in a warm environment. Bottom line is this: we may get less phagocytes getting to the wound bed itself because of vasoconstriction. The phagocytes that get there may have less capability of producing ATP because it's in a hypoxic environment, which may make the phagocytes less effective, which means that the bacteria may win, and this will increase the rate of infection. Another idea is that when you take off the wet-to-dry dressing, it's going to disperse bacteria in the immediate vicinity. It may get on the patient. It may actually get on the healthcare provider. And not too far in the distant past, the United Kingdom was thinking, well, you know what? Maybe when our clinicians make rounds, they should not wear neckties. Why? Because this can be a vector of transmitting bacteria from one patient to the other to the other. What happened to that? I understand from one of my students that indeed, not only in the United Kingdom are they recommending that the clinician not wear neckties, but they also have short sleeve shirts. I saw this in the U.S. surgical literature a couple years back in a throwaway magazine, but I knew it wouldn't come to the U.S. because we're not really nationalized medicine, at least at this point in time. So the disadvantages of wet to dry dressings, it is meant only for the inflammatory phase because it's a debrider. It's inappropriate to place it over a wound that's in the proliferative phase because then you're not really dealing with non-viable tissue. And what's it going to do in the proliferative phase? It's going to get rid of the granulation tissue and maybe destroy the epithelialization. There's this incorrect perception that wet to dry dressings, being gauze, saline, and tape, is most cost efficient than any other advanced direct dressing. That's a misconception because the advanced dressings may heal the wound up quicker than what wet to dry dressing do. And because we're having moisture in the peri-wound area, as you can see in the lower photograph, we can develop this maceration. So, wet to dry dressing utilization is considered substandard wound care, not just by me, who I represent Wound Care Education Institute, but look at this group here on the slide. CMS says that it's substandard care. I'm going to point out a journal that was just distributed at the WOW 2019 convention. And this is a journal of the Journal of Wound Care, consensus document, international experts. They met. And this was published in March of 2019. The purpose of the journal was to encourage the utilization of a new acronym for wound bed prep. The prior acronym is TIME. T stands for tissue management, where debridement falls under. I stands for inflammation, infection control. M stands for moisture balance, and E stands for epithelial edge advancement. They wanted to convert this to timers, where R stands for repair, regeneration, and S stands for social issues with the patient. March 2019, the international experts, one line on page 30. The older traumatic method of wet to dry dressings is now not recommended. I let the others do the dirty work for me. Why? Why are wet to dry dressings still being ordered in spite of considered substandard wound care? And this has been going on for a while. Well, some may be related to the clinician's training and clinical experience. I trained as a medical student, surgical resident in the 1970s. What were our options for debridement? Sharp debridement, some irrigation, and wet to dry dressing. We used an enzyme there that you can't get anymore. We didn't think about things such as maggot therapy or other things. We didn't really understand our capabilities with debridement. And anybody who was trained at that point in time will tell you the same thing I'm going to. I have healed wounds utilizing wet to dry dressings. No question about it. But at what expense? The expense to the patient. Delayed in healing, pain, and bleeding. They may use it not knowing all the other options, that they may say, well, I have this inflammatory phase. I have non-viable tissue. I need some sort of debrider. They flip to wet to dry dressings. Or this concept, wet to dry dressing therapy is financially feasible because all you're going to put on that wound is gauze, saline, and tape. Well, if it delays the wound healing compared to a more advanced dressing or technique, then it is not financially feasible. Part of this may be two reasons why we're having this webinar. They may be unfamiliar with the negative aspects of WettoDry dressings. That's all they know. The only thing in their toolbox is WettoDry dressings and a sharp debridement. They'll pull WettoDry dressings out. They may be unfamiliar with other advanced wound care dressings. So there are reasons why WettoDry dressings is still ordered. I made a case that it's ordered very frequently. From that review, that 2-year review, it was ordered 42% of the time. Is there enough evidence to exclude WettoDry mechanical debridement techniques from 21st century wound care? Without a doubt, as far as I'm concerned, yes. And this should be considered a all or none proposition. WettoDry dressing, non-selective mechanical debridement, did serve its purpose in the past, but it should now be discarded. We take care of patients. We are clinicians. We are scientists. Our laboratory is the patient. And research is being done every day of the year. Thousands of research is going on, and we want to improve what we're doing. WettoDry dressing served a useful purpose, but it now should be discarded. Let me give you an analogy. When I trained in the 1970s and practiced in the 1980s, if I was going to do an elective gallbladder operation or an emergency gallbladder operation, it was always an open cholecystectomy. That right subcostal margin incision, that big incision. Patient would be in the hospital a couple days to maybe a week plus. It was always the open cholecystectomy. The very end of the 1980s, early 1990s, in this country, they started to teach laparoscopic cholecystectomy. Smaller incisions, much less pain, patients able to get home sooner and able to function a lot quicker. If I was looking at the standard of care now, for me to schedule somebody for an elective cholecystectomy, it would be a laparoscopic cholecystectomy. And the vast majority of the time. Versus 70s, 80s, it was an open cholecystectomy. That's what research does. It improves us. It improves our care to our patients. Now, I mentioned that WettoDry dressing, non-selective debridement, has served its useful purpose. I think it's time to move on. It's not good enough for me to tell people they should stop doing something without telling them what they can do instead. So let's explore the debridement options. As I mentioned before, there's two categories of debridement. Selective debridement, where only the non-viable tissue is removed. And underneath that, it'll be autolytic, enzymatic, and biological. Then the non-selective, where the non-viable tissue is removed, but also the viable tissue has to be sacrificed, will be the non-selective, or WettoDry dressing fell under, as well as sharp debridement. So let's explore the debridement options. Autolytic, the first selected debridement. What it does is it's going to use the body's own enzymes to dissolve necrotic tissue within the wound. What's going on? This is your phagocytes, your neutrophils, your macrophages performing phagocytosis. They're going to surround, they're going to ingest, they're going to digest foreign antigens because they have proteolytic enzymes in their cell body. What do? We need to maintain a moist wound environment. So if the wound bed is dry, we need to add moisture. The only category we'll talk about is hydrogel. That's 90% water. If exudate's an issue, we need to absorb it. We may start out with a foam, hydrocolloid. If that doesn't work, alginates can absorb more than that. If that doesn't work, consider a hydrofiber, such as Aquacells or Convitex Aquacell. However, autolytic debridement is the slowest form of debridement. And because of that, it is contraindicated over infected wounds. You may want to start out utilization of autolytic debridement if, let's say, you have a patient who's in palliative care, but be ready to add other types of debridement, or somebody who's on anticoagulants, but again, be ready to add other types of debridement. So that's autolytic debridement. Enzymatic debridement. We only have one enzyme these days. The enzyme is collagenase. Trade name is Santal. Years ago, people used to use a papain-urea enzymes, the panophils, the accuzymes. They thought they were a lot more effective. Zenoderm had trypsin in it. Again, in the 70s, we used to use something called elase. I don't think you can get that nowadays. So the enzyme collagenase is selective. It will not harm healthy tissue. But Santal, a lot of people feel that it is not as effective as those other enzymes. What can we do to improve its effectiveness? First of all, once-a-day application. Next, keep it in a moist environment. In a dry environment, the Santal does not work well. The other reason why Santal may not work well is it works over a very narrow pH range of 6 to 8. Anything that takes us out of that pH range will make Santal potentially less effective. For example, the heavy metals, such as silver. You probably do not want to utilize a silver dressing with Santal. Enzymatic or acetic prep, acetic acid prep. You probably don't want to do that. That'll lower the pH out of that 6 to 8 range. And be careful of bacteria. Right now, Santal ointment is the only FDA-approved enzymatic debrider. It is presently marketed and manufactured by Smith Nephew. And the last form of selective debridement is biological. This is the application of live maggots onto the wound bed itself. Yeah, there's a yuck factor to it, but these little dudes work pretty good. You might want to consider that if you have a stalled wound, because not only can they help debride, but they can help promote the growth of fibroblasts, which is what we need in the proliferative phase of wound healing. You're going to leave them on for about 1 to 3 days. Multiple applications are the norm. But we used to be able to get in the United States something known as a bio bag. It's sort of, the maggots were in like a tea bag, and you laid it on the wound, and you got some debridement, but it's not as effective as laying the maggots themselves directly on the wound. Why? Because on the maggots, as they crawl on that wound surface, they have this fibrous, this ring of, I don't want to say ring of thorns, but it's just going to mechanically debride that area too, in addition to the enzymes that the maggots produce. So biological debridement is the last form of selective debridement. I talked about autolytic, enzymatic, biological. Let's talk about mechanical debridement, non-selective. This is where WettoDry fell in place. This is where external forces that use is great enough to separate or break adhesive forces of necrotic tissue. In the lower photograph, you see whirlpool. Combination of whirlpool plus irrigation is known as hydrotherapy. With irrigation, we want to use 4 to 15 psi. Manufacturers prove this. PSI stands for pounds per square inch. Many years back, when the water pick first came out, a lot of surgical departments bought some because they thought this would be cool to go to the patient's bedside with the water pick system, put the solution in the reservoir, and just blast the wound bed with the water pick. The problem is this. The amount of pressure that the water pick generated was greater than 15 psi. In fact, it was around 80. And so any surface bacteria were actually flushed into the depths of the wound. What you may want to consider in the upper photograph is the use of ultrasonic debridement. Scrubbing can act as a good mechanical debrider. There are some monofilament brushes out that do a nice job with less trauma to the patient's wound bed itself. And here's something else that you may want to consider as mechanical debridement. I do. That's the utilization of negative pressure wound therapy in combination with installation of an irrigant fluid. You place the fluid in there, it sits there for a while, then you aspirate it back for a couple of hours. This will help get rid of non-viable tissue. By definition, that would be a form of debridement. And lastly, sharp debridement, non-selective debridement. Regardless of where you do this, this needs to be done under sterile technique. Sterile prep, sterile drape, sterile instruments, and a sterile dressing on 24, preferably 48 hours post-procedure per CDC guidelines. It can be done at the bedside. It can be done in the operating room. Now, to me, we should consider utilizing it as the first technique if there's a questionable underlying infectious process, a bioburden process underneath that non-viable tissue. Some of the research that I review is suggesting that, sharp debridement works, but it worked better if we did it more frequently. The idea of seeing a patient once a week, making rounds on them, let's say in a long-term care facility, do the sharp debridement, and then in the meantime use something like an enzyme or some other technique of debridement may not be frequent enough, because within 2 to 3 days, the bacteria at the wound bed can start being protected with biofilm. And so the idea is that with sharp debridement, we probably should be utilizing it at least twice a week, if not 3 times a week. Going back to this biofilm concept, certain things that I already mentioned will break through the biofilm. The maggots will, some of the scrubbing will, sharp debridement will, and so we always need to keep this in consideration. Okay, so those are our debridement options. What about our dressing options? Remember, about 3/4 or 75% of the dressings that were retrospectively reviewed were used inappropriately, and they were used in the proliferative phase of wound healing. So let's go through the dressings that one may utilize in the proliferative phase and other phases of wound healing. And I'm going to go from the least absorptive to the most absorptive dressing. So the hydrogels. The hydrogels are basically water, 90% water. It's used to add moisture to a wound bed. If there's non-viable tissue there, it'll help soften the non-viable tissue, which will help debride that non-viable tissue. Some of the hydrogels actually will have some antimicrobials in it, such as silver, hypochloric acid. Hydrogels, to me, are the best options to be placed over viable live tissue. Fascia, tendons, ligaments, muscle, cartilage, bone, and include granulation tissue. All that is viable tissue. The natural environment of our tissue is a moist environment. This is where hydrogels will play a role. What about your transparent dressings? Now, your transparent dressings actually have no absorptive capability. It's going to immediately waterproof the tissue. Some of them can be left in place for 3 to 7 days. Because it does not absorb anything, the transparent dressing will maintain a moist wound environment. To me, remember I said that bacteria is able to penetrate 64 layers of gauze? Well, put down the number of layers of gauze that you want, and then put a transparent dressing on top of it, because that comes out of a sterile container. So it may be the ideal sterile operative taping versus the rolls of tape that are found in drawers, nurses' pockets, bouncing on the floor, and things like that. Transparent film is contraindicated over infected wounds. There's going to be 2 dressing categories that are contraindicated over infected wounds. One is a transparent film. Let's talk about contact layers. As an instructor of wound care, I tell my students that this is a dressing that they should utilize more and more and more because of its sole goal. And what's the goal of the contact layers? It's going to protect the wound bed from trauma. Trauma may be just dressing changes. It is always the first thing that's applied to the wound bed, so that means it's always a primary dressing. When you utilize negative pressure wound therapy, to try to prevent the granulation tissue from eroding into the foam or the antimicrobial dressing gauze, put a transparent dressing in between. Now, where you change other dressings quite frequently, transparent dressings, quite often you'll just change like every 5 to 7 days. Some of them actually come with silver involved with them, and that can give you some antimicrobial benefit. Collagen dressings. Collagen dressings are really intended for the proliferative phase of wound healing. It's going to help our tissue, the deposition of collagen, in an organized fashion. However, it does have an important function in the inflammatory phase. Part of the reason why the wound bed is not progressing in the inflammatory phase is because the phagocytes, the neutrophils and macrophages, are leaving proteolytic enzymes behind. A specific subset of these proteolytic enzymes you may have heard of, matrix metalloproteinases, or MMPs. And these are enzymes that use a metal as a cofactor. And usually the metal is zinc. Now, where a collagen dressing can help in the inflammatory phase is if you have a significant amount of proteolytic enzymes that are destroying the newly laid collagen that the fibroblasts are laying down, or destroying the cytokines or chemotactic molecules. What the collagen dressing can do is they can attract, and actually the dressing can be destroyed by the proteolytic enzymes itself. But that we don't care about because we pitch it when we change the dressing. So it may dilute the effect of the proteolytic enzymes on the wound bed. And so the collagen dressings can have a function not only in the proliferative phase of wound healing, with the deposition laying down of the collagen, but also the inflammatory phase, trying to get rid of the excess proteolytic enzymes. Let's look at hydrocolloids. Now, hydrocolloids will absorb more than the transparent dressings. Contact layers don't absorb either. They'll absorb about the same as a foam dressing. They're a totally non-occlusive dressing. That means nothing from the outside gets in, nothing from the inside gets out. That's why we see these backing of our appliances for our people who have ileostomies, colostomies, even our wound pouches. It provides the best insulation from the environment because nothing from the outside can get in. It is our only category that's totally occlusive. Now, when you remove a hydrocolloid, there may be an odor left behind, but this is not a clinical odor because this goes away with cleaning the wound bed. Or there may be a residue that's left behind. Hydrocolloids, like the transparent dressings, are contraindicated in infected wounds, probably related to this totally occlusive benefit. You may use the hydrocolloid under an Uniboot, venous insufficiency wrap, or total contact cast. So there may be a unique odor when you change that dressing and the casting system 5 to 7 days later. If you look at the lower photograph, you may want to window pane your wound, and this will allow better adherence when you utilize negative pressure wound therapy. You'll get a better airtight seal with it, with the use of a hydrocolloid in a window pane mode. Now, where you cannot use a hydrocolloid over an infected wound, and you want to use it under a total contact cast or a wrap, you can use a foam dressing. They absorb about the same. And these you can use under or on top of an infected wound. It provides good insulation. The outside layer is water resistant, can be left in place for 3 to 7 days. It's our warmest dressing, which means we're going to have less vasoconstriction under a foam dressing than any other dressing we have. If you have hypergranulation tissue, that's where the granulation tissue goes above the plane of the skin. That needs to be knocked down so the epithelial cells can go across. We can do this with a foam dressing with slight compression. Other options would be a chemical cauterant such as silver nitrate or sharp debridement. Like the hydrocolloids, it may be left under Uniboot, venous insufficiency wrap, or total contact cast. They may come with various antimicrobials or surfactants in it. If you notice the lower photograph, you have that pink foam dressing. I believe that is the brand name Polymem. Polymem has a surfactant in it, which is a soap-like solution. Manufacturers say that when you change the Polymem, just take off the old Polymem and put a new one on, and don't clean in between, because that could decrease that effectiveness of the surfactant in it. Again, if you need the absorption that a hydrocolloid can provide, but it's an infected wound, go to a foam dressing, because a foam dressing can absorb about the same as a hydrocolloid. You need more absorption than a hydrocolloid or a foam? Go to an alginate dressing. These are dressings with calcium and sodium fibers made from seaweed. They absorb really quite well. Not the best, but very, very well. You can use them to control moderate to heavy wound drainage. What's moderate drainage? You take a dressing off, 25 to 75% of your dressing has exudate on it. Heavy or copious, greater than 75%. What will happen with the exudate is that the fibers of the alginate will become a moist gel-like consistency. This will assist with autolytic debridement and will maintain that moist environment that we're looking for. The other thing is, the alginates have hemostatic properties. So when you're in the trenches and you're doing sharp debridement, let's say at a long-term care facility, and you know the patient is going to go back on aspirin or is on aspirin or Plavix or an anticoagulant, what I usually will do is I will make my primary dressing an alginate because it has its hemostatic properties, and then a secondary dressing, whatever I want to use on top of that. And then with the instructions, after a day or two, saturate everything before you take that dressing off so you don't get unnecessary bleeding. The way the alginates have hemostatic property is that they donate calcium ions to the wound bed. And we always worry about products being absorbed in the wound bed in the pediatric population. And for that reason, the calcium alginates are contraindicated in the pediatric population. It's not for use in dry wounds. How can you tell? When you go change the dressing 3 to 5 days later, you have the same fibers that it looks like when you put on initially. Some clinicians will use a hydrogel with an alginate. This makes no sense to me. Why? Because you need to have a certain amount of exudate for the alginate to be effective. What is a hydrogel going to do? It's going to get absorbed by the alginate, not by the wound bed. And now you're going to have less absorptive surface of the alginate compared to what it would have been if you placed it on the wound without the hydrogel. Some of them have silver with them. Some of them are impregnated with honey. Composite dressings, some of these can absorb small to some absorb heavy amount of exudate. It's a combination of two distinct dressing types. You have your absorptive surface, plus you have the adhesive about it. To me, this is the ideal operative dressing because not only does the adhesive pad come out of a sterile container, but so does the adhesiveness with it. If you have areas that are difficult to get a dressing to adhere to, try a composite dressing. Wound fillers, these will absorb more than the alginates. They're basically used to fill cavities, and they have good absorptive capabilities. Then you have, lastly, your specialty absorbers. They, too, will absorb better than your alginates, highly absorptive fibers. There's a subgroup known as the hydrofibers, and a trade name would be Convidex Aquacel in it that you can see in the lower right photograph there. Some of them may have antimicrobial impregnated in the fiber. For example, Aquacel. If you get Aquacel AG, that has silver in it. But Aquacel AG does not kill the bacteria topically. It has to get absorbed into the dressing, and now the silver in the dressing will get rid of the bacteria. So in summary, wet-to-dry dressings have been employed by generations of clinicians over many, many decades. At the time it worked, but they didn't have many other options to use at that time. We understand and we've believed the principles of moist wound healing since 1962. George Winter's study, where he showed that a moist wound will heal twice as fast as a dry wound. At this point in time, not only does Don Walheim say that wet-to-dry dressings is substandard care, but WCEI, CMS, international expert clinicians will say that. We have other options. Wet-to-dry dressing should be completely abandoned at this point in time. There's no question it's hard to adapt new technology in any area of medicine, but we're scientists. Change is extremely difficult, but the time has come for change. And we can say this because of the research that has been done and up to this point in time. So I do want to thank everybody for attention. And I turn the PowerPoint program back to Jason.
Thank you, Dr. Wolheim, for such a great presentation. This concludes the CE portion of this webinar, and we will move on to our Q&A session. You may begin typing your questions in the questions box if you haven't already. While we are waiting on your questions, I am going to send out a poll to everyone. WCEI and Reliant would like to know if you're interested in information regarding our skin and wound management, diabetic wound management, ostomy management, or our nutrition wound management courses. Go ahead and launch that poll now. So please select yes or no to learn more about the courses we offer to take the next step in furthering your career. We'll give everyone a few moments to answer that. All right, we'll give everybody about 10 more seconds to answer that poll question before we move on to the Q&A session. All right, thank you everyone for answering that poll question. So now we'll move on to some Q&A questions we have for you, Dr. Wolheim. Our first one is, would applying a warm saline moisted gauze dressing decrease the amount of time it takes for the wound to return to optimal temperature?
The question was, if you add a warm, moist dressing, saline dressing, will that decrease the time? It will decrease it from the basal constriction point of view, but again, we're talking about gauze and saline. I think we have better options. If you're interested in the warm, lean towards the foam dressing because that is our warmest dressing category.
All right, thank you, Doc. Our next question is, what is the standard for wound care after removal of a wound vac? They said we get a lot of MDs ordering standard wet-to-dry dressing after a wound vac is discontinued.
Well, I'm presuming, and can I make this instead of the KCI vacuum assisted closure group, but let's talk about negative pressure wound therapy. What is standard of care? It depends upon what you have and what the wound is. More than likely, you're in the flipperative phase of wound healing. And I would go to those dressing categories that I just went through based upon their overall absorptive capability. Applying wet-to-dry dressing now on top of a proliferative phase is definitely not standard of care. Now, there is a fine line that we have to understand that it is not research supported. But standard of care, many people are doing this. I don't have the answer for that in regards to the fine line, but I would say that this is not supported by the research, and the wet-to-dry dressing should be eliminated either in the inflammatory phase, but definitely in the proliferative phase where debridement is not indicated whatsoever.
All right, and our next question, do collagen supplements help speed up wound healing?
Do collagen supplements help speed? Are you talking? Is the author talking about the systemic supplements that somebody takes? We don't know because this was typed in. Let's just say nutrition in general. You need to have a patient who is in the anabolic state. That means that the protein that they're taking is more than enough needed for the maintenance of the body as well as wound repair. And that's an anabolic state, and that's what we would be looking for for wounds to heal. What I stress in my classes is the setting up of the multiple disciplinary wound teams. And you definitely want to have dietary involved with it because they can keep an eye on your patient from a nutritional point of view. It's like going back to that building, that 80-story office building analogy. You got the building up, and now you're going to go ahead and everything's protected. You're going to put down the carpeting, the painting the walls, and this and that, put in electricity. But what if only you had 60 stories worth of plumbing and you worked on the 75th floor and you had to use the bathroom? You'd have to go down 15 flights of stairs. What the body needs is everything, and they need it in a higher amount. For example, a patient who's going to maintain their normal body, the adult patient, they're going to need about 0.8 grams per kilogram of protein per day. If they have a wound, they're going to need 1.2 up to 1.5 grams per kilogram per day, a lot more. And so if you're referring to the collagen supplementation, I would talk about the just big general category, nutrition in the patient. Hopefully I answered your question.
All right, and our next question is asking any tips on how to gently change the minds of those more stubborn physicians who continue to order WettoDry? This is a problem in home health.
Well, do I have any tips? Do not underestimate the value of free food. And what you can do is you can have your own webinar party. You can actually, I believe Shields will have this readily available to produce, to get doctors there, speaking as one of those critters, not only free food, but pay attention to things such as pepperoni pizza. They'll get most people there. Now, dietitians may not show up for pepperoni pizza, but doctors might. And have a webinar party. You have this one. I'm sure it'll be available for you. I presume it'll be available for you in the very near future. So, and if you have that and you have a good pepperoni pizza, give me a call. Maybe I'll show up myself.
Our next question. In hospice, WettoDry is still used and is an alternative since negative pressure is still considered aggressive treatment. In your opinion, what will be a better alternative that maintains patients' comfort?
Well, first of all, if you were in a hospice, I don't know the price values, but anything that you can use other than WettoDry, I would think something that would stimulate autolytic debridement. I would consider it, and again, it depends upon the wound. If you flash a picture of a wound here and you got 10 clinicians here and ask how they would handle it, you get 11, 12 different answers. I would lean towards something like the Santos of the world, the enzymes. I would look towards something like the debrider, the mechanical debridement, such as a monofilament type of scrubbing of that area. But I would try not to use WettoDry dressing. I think I made a good case for that.
All right, and we'll get a few more questions in here. Which is your preferred dressing choice for infected wound if hydrocolloid and transparent is contraindicated?
Which is my preferred dressing for a infected wound? It depends upon the clinical situation, as well as it depends upon the amount of exudate. If the exudate is just a minimal amount of exudate, less than 25% of the dressing you take off, I'd use a foam. If, however, there's moderate, 25 to 75%, or large copious, I'd consider an alginate. But you can get the foams that have antimicrobials in it. You can get the alginates with silver. And more than that, I would consider something like Aquacel with silver. The key that I would do is don't use any extended wear dressing on any one period of time. You need to be able to look at it at least every other day, if not daily. So the utilization of a dressing under an infected wound, we cannot use a total contact cast with a diabetic foot ulcer on an infected wound. What we can use is a removable cast walker. It's sort of a clamshell, and you can apply it over and over again. So you put down your foam or your Aquacel or your Alginate with silver, and then put in the clamshell, which will offload that area, and take a look at it every once a day or every other day at the most. So that depends upon the amount of drainage.
All right, and this will be our last question. We did get a lot of questions from everyone, so we're just trying to grab the big ones
Thank you.
from everyone. The next question says that they work with a physician that insists there is no difference in healing outcomes for wet to dry versus other dressings. Are you aware of any studies that they can show them?
Yes, there's many studies out there. I think if you download the pamphlet that goes with this, look at the references there, and this can direct you there to studies. A doctor, why am I drawing a blank on her name? I'm drawing a blank on her name. The study is called "Hanging Wet to Dry Dressings Out to Dry" or something like that. Lisa, and I'm sorry, I'm drawing a blank on her name. In any event, yes, there are studies that show that. I would first go to the workbook or the guidelines that we have, the printout, it's 10 pages, and look at the reference section. That's what I would do.
All right, thank you, Dr. Wolheim, and thank you everyone for submitting your questions. Apologies if we could not get to yours in time. We would like to thank Dr. Don Wolheim one last time for an excellent presentation. As a final reminder, you will receive an email within 48 hours with your evaluation that must be completed before you obtain your credit. Thank you again for attending today's webinar, and thank you for everyone for being patient with us as we worked out the technical issues. Have a good
Thank you.
afternoon, everyone, and keep healing.